How many people in the US at least are using robotic technology with surgeries in your field, in orthopedics?
I think now it's probably about 50%.
Okay, it's getting there. Okay, I thought it
Yeah,
would be less, but
it's
that's
getting
pretty
there.
good.
It's about 50%. And when I say robotic, I also say like some kind of guidance. There's some computer guidance system or robotic systems that are used. But remember, the robot that I use is called the Mako robot, Mako. It's made by a company called Stryker. There are other robots. The haptic technology that I was talking about that makes sure that you're in the right space and all that stuff is a proprietary thing that only Stryker has. I don't get paid to say this. My opinion, that Stryker robot is the best robot in the world as far as in orthopedics,
Mhm.
because the other robots don't have that technology. They're not able to make the cuts and the positioning as well as the Mako robot. And so I think that there's a lot of people using some systems, but some systems are better than others.
All right. Well, it's a real pleasure to have Dr. Jason Snibbe on the show. Did I say your name right?
Yes, Snibbe, that's correct.
Snibbe, welcome.
Thank you so much. Thank you for having me. I'm excited for this great podcast.
It's actually today, I just mentioned to you, the second orthopedic surgeon I've interviewed in one day. So you can tell I love this topic. Obviously, people who've been following me know I've had two hip replacements, and I find it so fascinating. And after this experience has been not a fun experience, especially I'm only 55. I had them when I was 54, but I guess there's a reason for this to happen. And I need to spread the word that shit happens. Like sometimes we need to get replacement.
Yeah.
And yeah, and you are very well known for doing the hip replacement of what's her name, Kris Jenner. I saw that post,
Yes.
and you have also done sports teams, and you're just really well known in this world too, just like Dr. Avanda, who I just interviewed. So it's an honor to have you here, and I'm excited to talk this talk. But I think the women who are listening now will go either I don't want to ever have a hip replacement or knee replacement or any kind of joint issues. How can I avoid it? Or there'd be those who are like, okay, I think I need to do something. So we're going to try to clear the air on what we can do to avoid this. And then, of course, then what if we have to, how are we going to approach it? And I really want to talk about robotics because you're also, that's your specialty as well, robotic
Yes.
surgeries, which blows my mind. I think I was probably the last person on the planet to have a normal hip replacement. I missed the boat on this, literally. But I think what I've gone through, as I mentioned before, it seems to be, I feel like I'm too young to have a replacement, but evidently people are getting hip replacements at a younger age now. I can already name like 5 or 10 women I know in my age who are athletic, who've done nothing wrong. But what do you think is driving this trend?
I'm in my 50s as well. And you look at like our generation as far as the level of activity that people have done in their lives. And you look at the generation behind us, the level of sports and impact and motion that is the millions of miles that we put on our bodies is just as exponential compared to the generation ahead of us. And think about all the Pilates studios, all the gyms, all the exercise, the push for all these private clubs that have gyms and memberships. It's enormous. It's a multi-billion-dollar industry now. You also look at, you go on vacation and you go to a hotel, they have a massive gym. And you go there in the morning, it's filled with people. So I think that the exercise, the stimulus to exercise and the stimulus to keep fit and stay strong well into your late ages is so powerful right now. And the joints just wear out. And I think that sometimes the wear and tear on the joints just can't handle it. And that's why when you look at the ages between 30 and 60, the number of people ending up with joint replacements is exponentially growing. It's a huge area. So in my life, in my work, it's very common to see somebody in their late 40s coming in needing a hip replacement. We see it all the time, which is crazy. But it's very, very common because they're so athletic. And we even see younger people where they're high-level athletes, where they're running and jumping and cycling and playing tennis to such an intense degree that the body just wears out.
I'm a little confused too, or I'm not really sure what to think of that because I remember, I don't know why most people younger are getting these replacements? Not, is it because of wear and tear, or is it because something else? Like for me, in my case, I had hip osteoarthritis, and I couldn't understand. I mean, I'm athletic, but I'm not a pro athlete. And one of my doctors, my regenerative medicine doctor, she was like, "You're not a professional athlete. This is not." Professional athletes at your age, most of them are not getting replacements at this age. Maybe eventually down the road, it's an inflammation thing. And this is osteoarthritis. And I don't know if you are seeing people who are athletic and they break something, or what are the reasons why these younger people are getting replacements?
I think there's a few factors. I think one factor is in a hip, sometimes people have a thing inside their hip called impingement, where the shape of the ball, instead of being a round, beautiful ball that's like a baseball or a softball, it's like egg shaped. So about 20 to maybe 30% of the population has that anatomy. So those people, if they are very athletic and very physical in their life, they will end up getting early osteoarthritis in their hip, because instead of the ball tucking into the socket nicely, that bone will kind of jam inside the hip and kind of chip away at the cartilage. The other issue is dysplasia, right? Dysplasia is when instead of the socket covering the ball, it half covers the ball. So you kind of edge load the socket because it's not covering the ball completely. So people with dysplasia that are very, very active, those people end up getting early arthritis in their hip. If you're genetically predisposed to get some level of osteoarthritis in your joints, and then if you were just a regular person and just walked a little bit and wasn't that active, maybe that natural genetic osteoarthritis would present itself when you're 60 or 70. But if you add exercise to that, I think that it makes it very intense. It makes it wear out much quicker. So there's a lot of factors. And then we know that there's an enormous amount of hormonal factors, right? We know that all of our hormones are changing so much, and we were all in the dark about all this hormonal stuff. Nobody was paying attention to any of this stuff, whether it's a man's testosterone level, a woman's estrogen levels. We're seeing early changes in these things. We see men with low testosterone levels in their 40s sometimes, and that's probably a genetic thing. And we're seeing women perimenopausal in their mid-30s. And so those changes, and you can start getting the bigger picture, like maybe it's environmental, it's something in the water, it's something in our processed foods. There's a lot of reasons that people can, I don't think it's one thing, but I think that there's a lot of factors that present to us that can advance osteoarthritis in our body. And that's why we see it at such a young age.
Yeah, that makes more sense to me. And it's interesting you should say the hip impingement and the dysplasia. So is that genetic? You're born to have wonky bones, or there's nothing
Yes,
about that?
that's right. And so you're always predisposed. If you have that kind of anatomy, you're predisposed to developing osteoarthritis. I just saw a mother of 3 in my office yesterday who has dysplasia. She's 53, I think, 53, 54. And she needs a hip replacement. And she's like, well, how did this even happen? She said the same thing. I'm not an athlete. I'm just like, but you're active. You're running around. You're playing tennis. She plays a ton of pickleball. She's running around all the time. And at some point it wears out. But also I asked her, she went into menopause very early. And so that's also a factor. The loss of estrogen is a big factor in the inflammation, the inflammatory patterns in her body. And so we ask these questions now because we kind of want to understand and register what are these factors that are advancing the arthritis in people. And I think also the surveillance is important too. It's like we're also very sensitive to it. I can't tell you how many people come to my office that have the Pronovo body scan, right? They get a body MRI and they see a little arthritis in their knee, little arthritis in their hip. The surveillance and the watching of this stuff is at a very high level right now. And so I think that we're much more sensitive to see things, which I think is fantastic.
Yeah, it is definitely menopause, and the loss of the hormones accelerates a lot of things, including, at least I saw this too, my own self is like, wow, osteoarthritis was like, boom, suddenly you just fall off the cliff. And so that's really great that you're asking these questions. And so if there's a woman out there who's like, oh, well, I've got dysplasia or hip impingement, I'm active, Like, does she stop exercising? Because there's other risks facts if she stops moving, right? So what is, somebody's listening now, like, what do we tell them?
I think it's so interesting for me. Like when you talk about an orthopedic surgeon, you would never think about an endocrinologist being like part of your practice. I have an endocrinologist on speed dial on my phone. I'm sending tons and tons of patients to my endocrinologist that works like right down the street from me because I want my patients evaluated. I want their testosterone checked. I want their estrogen checked. I'm making sure that's part of the care of my patients because I want them to be at the optimal ability to stay strong, to decrease their inflammation, because if you don't address that in patients, you're behind the 8 ball. I also think that you talk about prevention and try to prevent things. I think that the technology that we have to replace joints is so good that it's much more important to maintain muscle mass, to maintain strength. If you're talking about the hips, working on your core and working on your glutes, keeping those muscles as strong as possible for as you age, because we know it's so critical to keep those areas strong because it keeps you active, it keeps you mobile, and it's preventative. It can prevent falls, it can maintain your balance, which is very, very important. And the one thing that I talk to patients about all the time is that as human beings, we all get stenosis in our spine. We get nerve compression in our spine. And so the natural electricity of those nerves into your gluteal muscles diminishes over time. And so you start losing muscle mass in your glutes because your back has arthritis. So it's really critical as you get older. I look at my back. I'm in my 50s. My back has got arthritis in it, a bunch of it, because I've been operating for many years, standing on my feet. And so it's so important to keep those muscles strong, because if you don't keep those muscles strong, they literally will disappear because the spine is compressing those nerves so much. So keeping your spine mobile, working on stretching your back, working on your core muscles and working on your glutes, I think is so, so important. And my number one, I'm a huge fan of Pilates. I think the exercise of Pilates to work on your core, combining Pilates with strength training and weights, I think is a great combination for men and women. And we've saved a lot of people from surgery by doing those exercises.
It's interesting you say about the spine and the glutes and that connection being lost, because the other day went to a pool and I saw the older women swimming. They all must have been in their 70s or 80s, and they all had flat butts. And I'm like, well, what's going on? Does this happen with aging? Is this what is normal? It's expected. Why are so many of us, and I think men as well, I don't think it's only women, is it because of that connection? Like, what do we do?
Yes, it's very common. We see a patient that comes to us where we get an MRI of their hip and you look at their gluteal muscles. There's 3 gluteal muscles, the minimus, the medius, and the maximus. But the gluteus medius is the most important muscle for the hip. It's really the engine, the stabilizer of the hip, the gluteus medius. And we see the gluteus medius and it's disappeared. It's like gone. When a muscle disappears, you get what they call fatty infiltration. It gets replaced by fat, and they have no muscle there. But the tendon is still attached. They don't have a tear, but the muscle disappeared. And they say, why did this happen to me? And it happens because of their spine. Because you get so much arthritis in your spine, it compresses the nerves, then all these muscles in your legs disappear. And that's why you see older men with these legs that are like sticks, that they lose all that mass. But that's because for many, many, many years, they're not maintaining their muscle mass. They're not maintaining. You're going to lose it. It's going to happen. You can't keep your legs as strong as you were when you were 30. You're going to lose it. But if you maintain it at a high level, if you're at 90% and you drop to 70 or 60%, you're still doing pretty good. But if you're at 40%, you drop to 20% or 10%, you're screwed. And if you fall and break your hip, God forbid, or you have an injury or a big surgery, you're done. You lose so much muscle mass, it's impossible to get it back. So I think maintaining that muscle mass and really stimulate what makes nerves work, what makes nerves like be powerful is muscle stimulation. The more you stimulate a muscle, the more you encourage the nerves to keep firing and stay attached. So that's a very good exercise to do, to strengthen those muscles, to keep the nerve connection strong.
Yes. So that's where the strength training comes in. I'm such a big proponent of building muscle and keeping muscle. And I'm always afraid of this, somebody going, oh, well, I don't really want to look like you, or I don't need to be, they're thinking about body composition. I'm like, it's not about body composition. And it's about strength and power, independence, and being mobile and doing the things that you want, and squatting and pick up your grandkids or whatever. It's hard to imagine ourselves as a 70-year-old or 80-year-old when we're in our 50s, but you'll get there, right? Well, hopefully, if you're lucky, you'll get there.
Yeah,
and
absolutely. And it also goes back to the, like, as you can tell, I'm a big proponent of checking your hormones. And I think that, like, how many women or how many men have you heard where they say, I don't know, I go to the gym 3 days a week and I feel like I'm not getting strong. I just feel like every day I'm there, I'm just like, it's hard to lift these things. And you look at a man who's got a testosterone level of, let's say, 300, it's extremely low. And you give that patient, gets on testosterone replacement therapy, not to become a bodybuilder, like you said, but just a little bit of testosterone to elevate it a little bit. And all of a sudden he says, wow, I feel I have energy. I work out. I feel like I'm building muscle mass. I feel stronger. I'm just better. And so I think that this is a part of the equation that we've ignored for so many years. And it's such a powerful tool, and we're realizing how safe it is. People were so afraid that something bad's going to happen, but all the data says it's very safe and it's really important. And then with women, with estrogen, we know that estrogen is a powerful anti-inflammatory. It's really critical to maintain the natural health of a joint. And so keeping those levels appropriate and easy, it's an easy thing to do, is so critical for women, because I think that how many, I've taken care of hundreds of women who literally go through menopause and then they come in, they have a bone-on-bone hip. And they're like, I don't get it. I never had hip pain before. And they go through menopause, the inflammation attacks them, and now they have a bone-on-bone hip. They're like, I don't get it. I developed hip pain 5 months ago. Now I'm bone-on-bone. How did this happen? And you're like, and then the question comes, when did you go through menopause? I just did. I went through the whole thing, and I haven't done anything about it. I never talked to my OBGYN. I didn't talk to an endocrinologist. So it's just getting that information out there and making it acceptable.
I think there's still so much work to be done in terms of hormones and prevention of many things. And I always think about myself. I started 5 years ago on hormone therapy, but I believe I was on baby dosages because I was in the beginning seeing doctors who were like, I don't know about giving this to you. And I'm like, give it to me. So they give me the smallest dose. So here I was thinking I'm on hormones. And I'm going, why isn't this working? It's supposed to be, my joints should be feeling better. I don't know why. And I always say, I wonder if I had those robust dosages and whatever that is. I don't know if there is any research to say, hey, you can reverse this or that, or slow the degradation of cartilage with X amount of estrogen in your blood. I don't know what that is, but hopefully that would be coming, because that would be a great guide for you and the endocrinologist as well to say, hey, here's somebody who's starting to feel joint issues. I'm not ready to operate on her. Like, it could be your hormones. It could be something else, right? You don't just jump into surgery, I guess, unless you see it's quite clear. But if you're talking to a woman in menopause, you're probably going to go, well, let's get her hormones optimized, but to what level in order to avoid a surgery is still unknown, right?
Yeah, when you do an operation, when you're working on people, they get inflammation from the surgery, right? So if their hormones aren't optimized, you're entering in an operation where they have tons of more inflammation than they normally would have after an operation. And then also you're trying to get the joint stronger. Like when your hip wears out, you lose muscle mass because the hip doesn't move, and you got to build that muscle mass back. So you're taking a patient, you're going to go to physical therapy and get stronger, but they can't get stronger because their hormones are out of whack. So you're just chasing your tail. You're not going to get anywhere. So I think it's really, really important to think about that. And I agree with you 100%. Our knowledge in this space is still primitive. We're still learning about where we need to be and what's optimal, what's the best place to be, and really what are the risks, what are the side effects. And it's probably not just as simple as estrogen and testosterone. There's probably many, many other things that we have to add to this. For example, the hot thing now is peptides, right? Everybody's on a peptide, right? BPC 157, TB 500. Many people are taking these peptides, and some people say it's for injury. People are taking it after surgery. People are taking it just after a simple injury, like a sprained ankle, or they pull their hamstring. We don't know. We don't know. What are the side effects from this? Is it okay to take for the rest of your life? Is it not okay? And we're just learning about that. And I'm very excited about it because I think it's a great adjunct to recovery and operations, but it's still in a gray space.
You mentioned BPC 157 and the TB 500, which I took myself because it was recommended by my regenerative medicine doctor to just get this. They're in the whole anti-aging space and prep me for this. And I know that you have a perioperative protocol that I'd love for you to dive into, but is the peptides, do you recommend your patients to get with that? Or
we have to be careful because the FDA puts a little bit of a thing on it that's not technically FDA approved. If the patient wants to take it, they can take it, but we're not allowed to prescribe it. But I think that part of our perioperative experience is adding that to the protocol. So taking BPC 157 and TB 500 has shown to improve healing, to improve the collagen synthesis, to heal tissue and improve the recovery. So we believe in that. And so in our perioperative protocol for our patients, we recommend it. And we have them start it about 2 weeks before surgery. They start taking it, and then they take it a month after surgery. So it's a total of about 6 weeks of peptides. A lot of patients end up taking it much longer than that because they're like, I want to keep taking it. I think this is great for me. The perioperative experience and the perioperative treatment of a patient has become an enormously powerful thing for us now to make sure that patients are optimized. Patients, when they have surgery, the metabolites in their body, the amino acids in their system, the nutrients in their body is so altered sometimes, and they don't really pay attention to any of these things. There's been a lot of research by NASA looking at muscle loss in space. And they found that basically a combination of several amino acids, multiple amino acids, is really critical to help maintain muscle mass. So we've taken that technology and used it for our patients. So about a week before surgery, they take it's a little packet. They put it in the water. The company that we use is called Accelerated Recovery. And they put a packet in there and they have this amino acid drink every day. But the other interesting thing we do is we make them, when you run a marathon, you carbo load, right? Mm-hmm. So think about when you have a surgery. You can't eat or drink anything after midnight. Then you show up, maybe your surgery's at 10 o'clock or 11 o'clock. You have the surgery, you go to the recovery room. By the time you get to your room and you get something to eat, it's, let's say, 4 in the afternoon or 5 at night. So you have been without anything to eat or drink for that long of a time. And so you are behind the 8 ball. And that's why patients sometimes feel horrible after surgery. They're just like, oh my God, doctor, I just feel horrible. I'm lightheaded. I have a headache. So we are now carbo loading the patients prior to surgery. So the night before, and sometimes we make them wake up at like 11:30 at night and just turn an alarm on and drink a carbohydrate drink to carbo load. So they have now all these carbohydrates inside their system to give them nutrients and to give them some caloric intake. So they come in not behind, and they wake up feeling great. And they're like, wow, I feel so much better after this surgery than when the last time I had an operation. And then we make them take the amino acids for another 3 weeks after the surgery. We also give them different things to help. One of the things that helps with pain, and also the way you modulate pain, is magnesium. So we make them take some magnesium, and we also make them take stool softeners to make sure they have the bowel movement. And we do lots of things and then we just tell them to stay hydrated and increase their protein intake. And some patients are like, I don't like this, I don't like that. So sometimes we tell them to go buy a whey protein, like a powder, and make a smoothie every morning. Do you like fruit? Put some blueberries or whatever you like, make a smoothie every morning and drink that to get that protein intake. And because they typically are not eating enough protein because they're taking a pain pill and they get nauseous and they don't want to eat. we really make sure that they're really on a great protocol, and it makes their recovery much better. We minimize muscle loss, and we make sure they're really, really optimized for the operation.
These are such great tips. You are speaking my language.
Yeah.
I have a whole recovery protocol that I created because I had all these wonderful guests that I've invited on my podcast who were able to guide me. And they all said very, very similar things to you. But the first time that I heard a carb load drink, because I was told don't drink, don't eat, don't drink, don't even drink water before you come in here. And it's got to be, I don't know, it was like 8 or 10 hours. And exactly like you said, I was in Spain getting my surgery and they don't eat till like 10. And I was like, I'm getting hungry here. Like I haven't eaten. It's like over 24 hours now. Like so it was, I got to struggle with that. Luckily I didn't have any nausea. I felt great actually, because I did a lot of the protocols, like you said, of the essential amino acids. And I think the stool softener was something I wasn't prepared for the first time. And I thought, gosh, I haven't gone in like 2 days. This is not normal. I mean, normal for you have surgery, but I was like, I'm afraid what's going to come out.
Yeah, exactly. No, you have to, that's part of your metabolism. We also, the other thing too that I forgot to mention was also about liquids. So we now allow people to have clear liquids up to 4 hours prior to the surgery. So they can wake up and drink a big glass of water, just drinking water. And sometimes we don't want them to drink gallons of water, but drinking some water prior makes you feel better and just adds that hydration. Because as you know, when you're sleeping at night, you become dehydrated. When you wake up, you're already dehydrated. So just getting that hydration going is really critical. I also think, go ahead.
Why do surgeons not want you to drink water before surgery?
So the idea about that is that if you have stuff in your stomach, you have food or water inside your stomach, if you get sick during the surgery, you become nauseous from the medication, you may throw up. And if you're asleep or you're not aware, you can inhale it. You vomit and then you inhale it into your lungs, and that can kill you. Because when all food contents go into your lungs, it can create a massive inflammatory response and infection that you could die from it. It's called aspirating. That's why they say not to do it. So yes, you can't, it's not good to drink like milk or like a smoothie or eat food prior to surgery. That's why you can't do that. But having clear water, like a cup of clear water, or maybe like 10 ounces, 12 ounces of water 4 hours before surgery is okay to do.
So what if somebody drank a lot of water before the surgery? They're also at risk of the aspiration?
It could be a problem if their stomach is full of water, but you metabolize water. Water goes through you digest water fast enough that it's usually not a problem. It's more of it's an issue if you eat. The eating is a big problem. So if you have food in your stomach, that makes you at very high risk for aspiration.
Okay, I get it. Okay, your perioperative, just to repeat, build your muscle, make sure you're strong going into the surgery. And then 1 week before and 1 week after, get your essential amino acids, get your carb load drink. That was something totally new to me. Magnesium for pain. That's a really good one as well. Is there a recommended dosage or is it different for everybody?
Yeah, I think I'd have to check the exact dosage in our protocol. I believe it's about 1,500 milligrams a day.
Okay, so you kind of load them up. It's like higher dosage of magnesium. And definitely getting the protein in is so hard. That's why I did bring protein shakes. I did, because you don't feel really like eating a whole lot right after surgery, I have to say. But I knew how important it was. So I was getting the essential amino acids, the protein, and through just drinking is easy when you know you need to eat, but you cannot. So I'm glad you like those.
Yes.
And the peptides, that's interesting. Are there any other peptides or other things that protocol you recommend pre or post surgery?
There's so many different peptides out there, but I think that those are the main ones that we prescribe, just TB500 and BPC157. I know there's many other ones. And again, this is kind of such a new field for everybody that we're just trying to discover what's the best kind of cocktail for the patients to have during that period. But right now, those are the best ones in our space for healing. What's interesting about BPC157 is also great for your gut. So there's a lot of discussion that's so good for your gut health. And so that's also something very important for bowel movements, for digestion, for all the things that can get messed up after an operation. I also think it's important to talk about in the perioperative period, your mind. And I think that a lot of people talk about surgery and being prepared and all this stuff, and people don't think about their mind. And I think that one of the things I talk to patients about is that you're going to be safe during this surgery. I'm going to be with you the whole time. I will be with you there in that operating room. So when you're asleep, we will be with you, making sure that you're positioned okay and you're taken care of. And I think that mindfulness around that. And I think that it's one of the things that I'm also very interested in is creating almost a mindfulness aspect of operations where patients can meditate and almost think about like, I'm going to be safe. Dr. Snibbe is going to be with me. I'm going to be okay. This is going to be a safe environment, because we see a lot of patients, especially these intense patients that are, let's say, CEOs of big companies or run movie studios or famous actors. They're used to controlling their whole life. They're like, I want to eat this and I want to only go to this restaurant. I want to go. They're in such high control. They can't let go. The idea of letting go and letting someone else control their body and their life for that 2-hour period is painful for them. It's very difficult. And so creating a kind of meditative aspect to the surgery where I'm going to be safe, I'm going to be okay, I'm going to get through this. Hip is going to be good, is strong and stable and good. And I tell them all the time, I go, this surgery is not like a fragile egg that can break so easily. It's so strong, and you can put as much weight on it as you can, and you can walk on it immediately, and you can move, to just encourage them that this is in a positive way, that you can get through this and you're going to make it. Because what I see a lot of is patients, right, especially the first couple weeks after surgery, fall into this depression. And we see it very commonly. They start feeling very vulnerable. They're like, oh my God, I'm 55 and I just had my hip replaced. I'm like, am I going to be able to walk again? Am I going to be able to exercise again? Am I going to get through this? Like they go into this like funk. And I think that creating more of a positive way of like, you're going to get better. Every day you're going to improve. Today you can start getting on your bike and riding your bike. Today you can start advancing, just pushing them and encouraging them to get out and do things. And I also encourage my patients to, after surgery, get out of the house. Have your husband take you out and go to lunch. Sit outside, get sun on your face, go have your favorite sandwich or your favorite salad. Feel like a human being, because a lot of the caregivers, like the husbands and wives or boyfriends or whoever, they're like, no, you have to stay home. You can't go outside. This is dangerous. You're going to get an infection. Something bad's going to happen. So like encouraging them to normalize their life, but also live a little bit. Don't feel not be in a prison. I mean, I'm sure you feel the same way. If I'm in my house all day long, I'm like, I got to get out of here. I just got to get out and see the world. I got to move. I got to exercise or walk. But having a patient walk around the block, it's encouraging them to kind of feel normal and feel like they're back into their life. So there are these little things that can make a profound impact on how people recover.
I have so much to say about that just because I've lived this experience. And
oh, yeah.
So definitely the mindset is so important. And I don't know what you're seeing with your patients, but I was anti-surgery for years. I was like, there's no way it's cutting me open. It's invasive. The body doesn't forget. I'm going to have to go to therapy. Like the trauma, like no way. And then you get to where you've tried everything, it's not working. And I made that decision. When you make the decision, I've seen this couple of my friends as well. You just say, that's it, bring it on. I cannot wait to get the surgery. I was begging, like, when? As fast as you can. I was so excited. I couldn't wait because I knew, and I think one recommendation I would say to get your patients is to talk to someone who's had a hip replacement already, because
100%.
they are cheering you on. They know exactly what you're going through. They know the pain.
Yeah.
They're on the other side and they're like, I cannot wait for you to get here. It's like when you talk to a post-menopausal woman. It's great on the other side. And so I think that was very helpful to know that your friends got through it, they survived, and they're living their best life. And when you compare it to where you are now, like you can't move, you're in pain. Like, why would you even want to extend that? So I think talking to those people, the stress is real. Like several days before the operation, I was waking up at 2 a.m., my mind racing. Oh my God, someone's going to cut me open. Someone's going to cut the bone off. What if I wake up in the surgery, which I did? My worst nightmare came true, but all
Wow.
this horrible things. So what I started to do, and this is I've recommended this as well to many people. There's neuroacoustic software. There's something called NewCalm, and Tony Robbins talks about it. And it's just, you listen to
Wow.
it, and there are waves that bring your brain into a meditative state. And so I just started doing this 3 times a day minimum.
Wow.
And the night before my surgery, I had the best sleep of my life. I didn't wake up. I was so refreshed. I was like, bring it on. I was so calm. I was so relaxed. I just kept listening to that all the way to the bed. I was putting this in my ears.
Wow. How great.
It was brilliant. And I did wake up from the surgery. I was totally relaxed. I don't think it was because of Newcom. I think it's all the drugs, but they put me back. But I just kept doing this, and it just stuck with me. And I still do it. It's like 7 months later. It's such a wonderful tool. But whether you use Newcom or something else, maybe it's binaural beats or get them to practice meditation, it's hard. I really like the Newcom because I always call it meditation made easy. And I've heard from women in my community who have anxiety and stress that raved about it. And I was just like, oh, it's a cool meditation thing until
That's so great.
I had anxiety. Like I never have anxiety, but I recognize this pain is like tightness in your chest. I was like, ooh, I think that's what anxiety is. And of course I'm free tomorrow, but that is something I think has been so helpful. And the other last thing that I'm going to mention, if it helps anyone who's going to get a surgery soon, and is I don't know if you can find a solution for this. I'm sure a lot of people get anxiety when they see this. When you're in a wheelchair and you go into the operating room and those doors open and that bed is like a Frankenstein bed, and you're like, whoa, that's for me. All the saws and the tools. It's impressive. I mean, I was already chilled. I was totally cool going in there, but if you're not doing your Newcom or whatever, I can imagine the panic. And as I was on the bed, and before the anesthesiologist poked me and I was going to be out, I said, there was like 10 people running around the room. I didn't know how I was going to do this, but I just said, excuse me, I don't know if I'm going to see you guys again because there's like 10 of you. And I just wanted to say thank you for taking care of me. And I know
that's sweet.
Hands. And then you just see this little smile because, surgeons and nurses, they all have their lives and kids running around and divorces and whatever life that you have. And I just felt better. And I see a smile on everybody's face. And you do have to let go. And you just say, you know what? These people have my life in their hands. It is very simple. But the more you give in, the more you release, the more faith that you have. I think makes the whole process easier. That when I got out of that surgery, like, let's do the other one. I can't wait.
Yeah, I think it's absolutely true. And I think that the people that come, like we sometimes have patients that come and they say, I want to make sure this happens. I want to make sure this happens. I want to make sure they're trying to control the whole situation. And I go, your plan is destined to fail. You can't control that. It's like you take a trip and you're like, I want to go do this. And sometimes you can't do it all. It's like you have to just accept life the way it is. And so you have to let these patients have a reality of like, you're going to be safe, you're going to be okay, but you have to let go and you have to relax, because the patients that come into surgery so hyped up and so trying to control everything, they have a horrible experience. They're just like, the nurse looked at me weird. This happened, that happened. There wasn't enough water in my cup. There wasn't enough. We can't be perfect. It's hard. It's like going on an airplane. Is your flight perfect? No. Sometimes they run out of nuts. They run out of the ginger ale that you want to drink. It's things happen. So you have to just be able to deal with it and be relaxed. And when the people that are so relaxed, those are the people that are great. And I think that the other thing I think is very important is you have to touch your patient. You have to touch somebody. And I believe that in the office, and I believe that in surgery. You have to shake everybody's hand. If they want a hug, you give them a hug, but you have to touch a patient because you have to connect to them and make sure that you feel connected to them, that they are seen as a person. So I always try to remember, I have a very good memory. I was blessed with a very good memory. So I remember many, many things about my patients. And so when I see a patient, I'll say, oh, how was your trip to San Francisco? I'll remember that they took a trip. Or I'll say, oh, you guys live in this part of LA. How was the ride in? How was the traffic? Just little things that make a difference. And sometimes they ask me questions. They say, oh, Dr. Snibbe, how was your weekend? Oh, it was great. I was with my kids. I did X, Y, Z. I try to humanize it. It's not like I'm a robot and I'm going to fix you and I'm just going to walk in there and like you're just another
piece of
Ford
meat
truck coming through the assembly line. Exactly. So we try to like be connected to people. And I think that makes a big difference. And I pride myself as being a surgeon that does that because I want my patients to know that I care about them and I care about their recovery and I care about their experience. And I think that a lot of patients tell me about their experience and they say, this is the best experience I've ever had with a doctor. It's been great. It's been wonderful. And we try to make sure we keep making that experience better and better. It's very important to be connected as people. We all want to be seen in life.
You're so right. And I told you this just before we recorded. I was watching some of your videos on your YouTube, Instagram, and I was just like, I can tell you probably have really good bedside manner. Yeah, people are really lucky if they get to have a doctor like you or you.
Thank you.
The touch. And I have a question. I got my surgery in Spain and people touch each other a lot. Like it's part of the culture. Like there's studies that have been done and how many times people will touch your arm as they're talking to you or touch your hair, whatever. Like it's all touching, you kiss and hug and out. It's all Spanish. So in my surgery, yeah, you kind of had a lot of that. And I felt it. I could literally feel like the healing. It's something strange, but you feel like you are seen, you are heard, and just that gentle touch. I do remember one of the second surgeons that was there, he came in and I was on the bed and he just put his hand on my foot. And he was saying, just gently move your foot. And he just kind of let his hand just sit on my foot. And I was like, it felt so good. I don't know what it was. It was just being kind. And I would imagine, I know that the US is much more careful, don't touch. And I think yoga teachers now, you have to ask before you touch people. It's like, that doesn't happen.
Yeah.
But how do you get around that? Is there any restrictions?
I mean, no, you have to read the body language of a patient. Some people like a hug, some people don't. But in my practice, many patients will hug me to say thank you and appreciate the care we get. And they'll go, Dr. Snibbe, can I hug you? And I go, well, of course you can. And so we get that sometimes. And some patients don't. Sometimes you just shake their hand. But I just think it's the contact. And I agree. Sometimes I put my hand on their shoulder and say, hey, welcome. We're going to get this surgery done. You're going to be okay. We'll be with you the whole way and follow you along and keep track of you. And so I think that's really important.
But people are scared. They're pretty scared and you are in control. That's the way it is. I wanted to ask you about because let's get into the robotics, because robotic surgery is I didn't really know about as I was searching for my prince surgeon or princess surgeon. And in Spain, it didn't seem to be an option. I was just looking for somebody who would cut me in the front, not on the side. And even that doesn't exist where I'm at. And I noticed that people who have an interior approach recover way faster than me. I had 5 days in the hospital with both of them. That's just standard of care.
Wow.
In the US, you just go home the same day. And I had a friend who wasn't even using crutches the first day. I was like, how is that even possible? But it shows you what the difference it is in recovery. And now it's all equal. But boy, I was impatient when I saw all my friends moving way faster than I was. But robotics is different. Tell us a little bit more about the robotics and what does that even mean? Like a robot doing your surgery? Are you actually there?
Yeah.
And how is the recovery compared to all the other types?
Yeah, so I think it's important to know the difference between robotics in general surgery or in heart surgery or lung surgery is different than robotics in orthopedic surgery. And so when you have a robotic surgery in heart surgery or abdominal surgery, the surgeon, they get access to your abdomen, but the surgeon is over there in the corner of the operating room running the robot as the robot's on top of the patient. So there's a separation. For us, the robot assists us in the surgery. The robot gives us guidance. So we still are working on the patient, dissecting into the hip and doing all that stuff. But the robot assists mainly in guidance to make sure that we're making cuts and preparing the bone in a way to accept the implant. The way robotics works in orthopedics is that we get preoperative CT scans. So let's talk about a hip. So with a hip, you'd get a CT scan of your pelvis. And specifically in your hip, we will size your implant. So we will know exactly what size your socket will be, the size that the stem will be, the part that goes inside your femoral bone, your thigh bone, and the alignment to make sure your legs are even and balanced. But where the robot makes a massive difference is it places your socket in the right orientation. So what you do is digitally on a computer screen, prior to the surgery, we work with the people that run the system and we say, okay, this is the perfect spot based on your anatomy, based on your alignment for your socket to be, the alignment of that socket in your pelvis. And so when we get into the operating room, we register your pelvis. So we put a couple of pins into your pelvis that have little spheres on them so the robot can see where your pelvis is in space. So if your pelvis was to move one way or the other, like little movements, microscopic movements, the robot knows exactly where you are at all times. And then we take a probe and register the bone so the robot says, this is where your pelvis is in space, and it melds that pelvic model on the CT scan to where you are in space. So it knows exactly where you are and where to put that socket. And so we're able to prepare the socket in what we call a single ream. Let's say your socket is a size 48. Usually in a manual hip, you'll start with a 44, then a 46, then a 48, and you'll say, oh, that looks good, and you put the cup in. In a robot, we know you're a 48, so we take a 48 reamer, we prepare the bone, and we put the socket in. It's very fast because we know exactly where we are at all times. So it makes the precision of placement of the implant better than we can do it. There's always some human error when putting things in, a little bit this way, but you know exactly where you are at all times. And so it gives a level of precision that's beyond what a human can do. It also works in a thing called haptic technology. So there's a certain depth that you want to put the socket in. If you go too deep, you can take too much bone. And also when you prepare the socket in a hip, it's called a reamer. It's like a cheese grater. And that reamer, based on where the bone is soft or where the bone is hard, can drift. It can drift around. It can move when you're preparing the bone. It can get caught on bone and move. Mm-hmm. The robot doesn't allow that. The robot will literally prepare it perfectly in the perfect position, and it will never go too deep. It has a hard stop. So I'm a big guy. I'm 6'4". I can lean on the robotic arm as hard as I can. It will not go too deep. It will stop you right there. And it's a very powerful technology that makes sure that you don't make any mistakes. And what's really crazy is if you take 100 of my hips and you line up all the x-rays, they look exactly the same. Like the socket and the alignment is perfect every time. It's so perfect that, like, when I used to do hips without the robot, you would see little differences. Like this cup is a little closed, this is a little bit, just little subtle things, like a few degrees this way, a few degrees that way. But it's perfect every single time because you know exactly where you are at all times. And it's so good. What I tell patients is that the most important thing is in our life, is in my profession, is reproducibility, right? You come to me and you have your hip done and you say, Dr. Snibbe's the best. He's so good. He did my hip. He's great. But then you send me your best friend and you're like, okay, do her hip. She's my friend. You did a great job with me. Fix her hip. So as surgeons, we feel pressure. There's pressure to make sure that you're doing a good job every single time, and you know where you are and you're perfect. You have to be perfect with these surgeries. These surgeries last the rest of your life, so we want you to be great. So for us, by adding that level of perfection, it makes us better than we can be, because you just can't be that good every single time. And I use the analogy, if you told me to draw a circle 10 times, each circle will be different every single time. And the circle's perfect every single time a robot draws a circle. It's perfect every single time. I think the technology is insanely accurate, and it's so perfect, and it's made my life wonderful because there's no surprises anymore. If there's a bone defect, if there's erosion, if there's a pelvic tilt or this or that. We know exactly where we are at all times. There's no guessing game. And a lot of surgeons sometimes don't, people always ask me, how come everybody doesn't use it? Because a lot of surgeons say, well, I know how to do it. I know where to put it exactly right. And it's true that maybe 70% of the time you're okay. The operation's good. I've done thousands of hips without the robot. But it's that 1 out of 20 or 1 out of 30 that is a little off, and the anatomy's a little strange, or the bone's a little harder, that you're not going to be as perfect. And it's like, why not be perfect every time? Why would you go and drive from Madrid to Valencia and not put it in your Google Maps? Why would you do that? You're just going to get lost 20 times. You know what I mean? It's like, why not embrace that technology and make it much better? And for me, it's transformative. I do all my hips and knees with the robot, and I'm going to start in a couple months do all my shoulder replacements with the robot. And it's incredible. The level of precision and perfection is just on the highest level. And we see it in our patients. My patients in total knees, they're bending their knee way past 90 degrees at 2 weeks. They recover so much faster. And so many physical therapists send me patients because this doctor, Snibbe, he sent a patient to our office and they're like 6 weeks ahead of everybody else. And they're just advancing so much better and being so much better. So it's all the things, not cutting muscle, not cutting tissue, being easy on the patient. And I think that the other thing that I am a big proponent of is just being gentle. I think that the key to surgery, the more gentle you are with the tissue, the less you cut, the less you are rough with the tissue, and the more easy you are on the patient, the better they do on the back end. I'm a big proponent of, for example, on a knee replacement, lots of surgeons use a tourniquet around the thigh that crushes the muscle of your thigh muscle. It's crushing the muscle. I don't use a tourniquet. I don't use any of that stuff because all of that creates trauma. So the less trauma they have, the better they do on the back end.
Oh my goodness. What a review, a glowing review for robotics. I just wish I could do that all over again.
Yes.
I
know.
Wow. But maybe for my knee, I got a torn ACL, so maybe I'll have to go and look into robotics or go to see you because it's unbelievable. I didn't realize what a big impact that makes for the surgeon. And the story you said about a friend bringing a friend, that's exactly what happened in my case. So now I know how my surgeon was feeling the pressure when my friend was like, take care of her. Like, you're the best, right? I mean,
exactly.
I'm lucky that everything turned out so far so good. I don't know, I guess, but it's much more guaranteed when you have such precision. And how long have you been doing robotics?
I've been doing robotics for about 8 years now, and it's been incredible. The knee replacements and the hip replacements, I've been doing both of them for that long. It's been incredible for me as far as the results that we get and just the level of accuracy. It used to be like certain hips were harder, like people with dysplasia or people with hardware and people with different complex things, but it makes those operations very easy and very precise. And so we don't really worry about the patient and the sizing, because we used to, it used to be very primitive. We used to try to measure on an x-ray and figure out what sizes they were, and it was very inaccurate and not very precise. And the sad part, the saddest thing for me is that why we talked about it earlier, is that why surgeons don't embrace this technology. They just poo-poo it and say, it's unnecessary. Why should we do that? And you just have to spend a day looking at it and understanding it's very powerful. We actually own 2 robots. We have a surgical hospital and a surgery center. We own 2 robots, and they're amazing. We use them for all of our surgeries. And the patients understand, when the patients understand it, they come in droves. They're like, I want it done that way. They're like, I know you're great, but I want that robot there too, because it's amazing.
It's very convincing. I'm one of those as well. I'm wondering, has it changed? I'm told that hip surgeries are very successful. Most people come out pretty well. Knee surgeries, they say, is more complicated. Is that true? Does the robot help with that difference?
Yes, the robot makes a big difference in the knees. And the thing that I always tell patients and everybody is that a knee replacement used to be done the same way for everybody. They would say, okay, you have to cut the shin bone, the tibia this way. You have to cut the femur with this much rotation. It was very primitive done. And still people do it that way. They call it a manual knee. And you were trying to balance the ligaments, and you were kind of like, it just wasn't a good surgery. Like in knee replacements, 20 to 30% of people that have knee replacements are not happy. They're just like, it's just not right. Or the patients will say to you, it just doesn't feel right. It just doesn't feel right. Mm-hmm. With a knee replacement on a robot, I think this is where it makes the biggest difference in the knee replacement, because what you do is you get a CAT scan of their whole leg. So you understand from their hip to their ankle, the alignment of the leg. And then during the surgery, you test the ligaments, where your ligaments are loose, where your ligaments are tight. And by taking that information, you get like a set of numbers. You can, on a computer screen, we adjust the implant by 1 millimeter rotations, to adjust it in all different planes to basically accept the way your ligaments behave. So your ligaments are going to behave different than my ligaments, and then your friend's ligaments. So you're literally customizing the knee replacement to fit into your knee with the way your ligaments behave and your alignment behaves. And so enormous. Like people say, well, how much better is it? I'm like, it's not just a little bit better. It's 1,000 times better. It's so much better that I don't think you can put a number on it, how good it is, because you're really customizing the knee to the way your body behaves. Again, this is an early technology, and we talk about AI. How does AI come into this? And there's going to be a lot of work done looking at outcomes, like how well patients do, and the decisions that we make in the operating room. And so by melding that information using AI, it's going to make a big difference in how we make decisions. So for example, someone has a certain knee with a certain alignment, they'll say, well, if you make these decisions in the operating room and you size it this way and position it this way, there's a 99% chance they'll have a great outcome. And so that's where AI is going to come in. But the knee replacement makes a massive difference. And also, like we talked about earlier, the haptic technology. When you do a knee replacement, there's a saw that's cutting the bone. When you do it manually, guess what? That saw leaves the bone, and it cuts tissue. So it causes more trauma, more injury to the knee. With the haptic technology in the robot, the saw will never leave the bone. It will never exit the bone. It's captured. It will never move outside of the plane of the bone. So you minimize the trauma to the leg. And also, with a manual knee, you know exactly where you are at all times. So if you're like a heavy person, you're an obese person, and you're trying to figure out where the leg is and how it's aligned, it's difficult, very difficult. And that's why in those patients, the complication rate goes through the roof, because you don't know where you are. It's very difficult. But now you have the robotic technology, you put a perfect knee in every single time. And just like we talked about with the hip, if you look at 100 of my knees, they're in perfect alignment and perfect positioning. And you just can't achieve that with a human eye. You just can't do it. It's impossible. And so it's a very incredible technology. And I tell patients all the time, I go, if I needed a knee replacement or hip replacement, if my parents, if anyone in my family, I'm not going to do it, but I'm going to get it robotically 100%. I want it done with the robot for sure, because it makes such a massive difference.
How many people in the US at least are using robotic technology with surgeries? With, let's say, just in your field, orthopedics, I guess.
Yeah, it's a great question. I think now it's probably about 50%.
Okay, it's getting there. Okay, I thought it would be less, but that's pretty good.
Yeah, it's about 50%. And when I say robotic, I also say like some kind of guidance system. Mm-hmm. Like there's some computer guidance system or robotic systems that are used. But remember, the robot that I use is called the Mako robot, M-A-K-O. It's made by a company called Stryker. But there are other robots, but the haptic technology that I was talking about that makes sure that you're in the right space and all that stuff is a proprietary thing that only Stryker has. And in my opinion, and I don't get paid to say this, my opinion, that Stryker robot is the best robot in the world as far as in orthopedics. Because the other robots don't have that technology. They're not able to make the cuts and the positioning as well as the Mako robot. And so I think that there's a lot of people using some systems, but some systems are better than others.
Yeah, I guess you're right. When you say robotics, I don't know, there's one, but there must be many out there. And you probably did
Yeah,
your
there's many. Yeah.
before you spend a lot of cash on a robot to, to guide you.
Yeah,
Super interesting. I'm wondering,
exactly.
do the robots, I do remember my surgeon, and he even took a photo for this because I was like, I wanted him to take a photo of my bone. I wanted to see everything. And I saw your Instagram where you actually have the you're doing somebody's leg. And I'm like, oh my God, I wish my
Yeah.
did that because I would love to see what was
I
happening. I know it's grotesque and a
yeah.
lot of people don't, but he did take a photo of the cut and opening the muscle. And he had these like clamps and he was like, your muscle was so strong. I did all my
Wow.
glutes, but it still didn't help. I did everything. But he said he was literally really hard. And to bang the implant into the bone is also very hard. So I'm wondering, do
Yeah.
robots help with opening like those kind of physical parts? Because he was like, me and my partner were like, like I don't know what he was doing. He just said it was really hard on a small person like me. Does that help, or is it just precision? Just look.
The robot doesn't do that. So that's where you need us, not cutting the muscle and dissecting into a hip and kind of getting into the joint and making those decisions as far as how to treat the soft tissue. That's all done by hand, by us, by getting in there and preparing the joint for the surgery. The robot doesn't do that yet. Probably the next version of the robot, the next thing that's going to happen is automation. So one of the things is that we still have to kind of see everything and have some level of exposure. But what's going to happen in the future is that you're going to make decisions about how to do the surgery. You're going to say, okay, this is the size, this is perfect. And then the robot will go into the joint and prepare the bone without the surgeon holding it. It'll be done all automated. And so that's the next version of it. In the United States, the FDA doesn't allow automation. We actually have the technology to do it, but the FDA doesn't allow it because God forbid if the robot goes crazy or haywire, a problem could happen. So there's a lot of liability involved with that. But I think that's where the next version of it, because imagine if you don't have to see as much and you can make smaller incisions and less cutting and you can put things in without actually visualizing it all together. It would make a huge difference as far as what we're able to do. So that's really where the next evolution is. It also creates a level playing ground because I've been in practice for almost 22 years now. I have a vast experience. I know there's a certain level of knowing and being a veteran of so many surgeries. And how do you make a surgeon that's maybe like a couple years in practice good at what he does and accurate and precise? And I think the robot provides that. It gives you a level of accuracy and precision that's very important. So people have safe operations, they have good outcomes, whether you have surgery in the middle of nowhere or you have surgery in a big city like Los Angeles.
The next level type surgery, is that being practiced in other countries? What you just explained, the sort of, yeah, that's not FDA approved yet.
Yeah, I mean, yes, there is some automation happening in other countries, like in South Korea, they have a company called Think Surgical that does some automation with knee replacements. So it's there, the technology's there, but it's evolving. It's evolving to, I think that we want to make sure that things are done properly, are really vetted and tested. So it's just going to take a little bit of time.
So we'll have to watch the Koreans and how that turns out for them. And
That's right. That's right.
and go from there. This is so
Yeah,
interesting.
absolutely.
It's so interesting. I heard that the robotic technology started in Cambridge in the UK. Is that true? Or is that maybe a certain type of technology?
Yeah, well, yeah, there was some computer guidance that was started there. The Mako system was actually started in Florida, in Fort Lauderdale, Florida. That's where it started. That's where it got its name because it was after the Mako shark. That's why they named it that way. So it was invented in Florida, and then Stryker acquired it after the technology got developed. But they only had, at the time, what Robotics came up with was with partial knee replacements, where you're just replacing one part of the knee. And that technology is incredible. So when you're doing a partial knee replacement, the level of accuracy and precision is very difficult to achieve manually. So there's a lot of patients that have very poor outcomes with that surgery, but the robot changed it. And it made it so accurate, the partial knees, that in some countries, you're not allowed to perform a partial knee replacement unless you use a robot because the data is so different. If you have it manual, it's so-so, but if you have it with a robot, you're fantastic. So that's where it came. So they had a hip platform and a partial knee platform, but then when Stryker purchased it, then they developed a total knee platform. And then now we're actually in the early stages of developing a platform for revisions. So when you want to redo a knee or redo a hip, and you have old parts you got to take out and you want to kind of figure out what you want to do, that technology is coming out soon as well.
Oh, wow. So exciting. But when anyone who's looked at a video on a hip surgery or maybe, I don't know, knee, but it's so primitive. It looks so, you're cutting off bone, banging in a thing. It's sawing things off. I'm wondering if there's the future of medicine, let's say regenerative medicine. I don't know if this is even know anything about it. Why can't somebody just come up with some kind of a gel or, I don't know, lubricant that can there or change the structure of the bone somehow non-invasively? Is there anything in the future that will be regenerate cartilage or help us avoid a surgery in the first place?
Yeah, I think that it's a great question. The problem we have is that we can grow cartilage. I can go take a biopsy of cartilage inside your knee or your shoulder and put it in a lab and grow it. But to connect it to bone, to make it connected to the bone and to make it resilient, where you move your knee or your shoulder or your hip, you move it around, after a couple steps, it disintegrates because it doesn't have the structural stability to stay on there. So we have the ability to graft cartilage into a pothole. Like, let's say all the cartilage is normal, but you have a little tiny hole, like a centimeter by a centimeter, that has a defect. We have ways to fill that hole if you have that in a young patient, like a young athlete in their teens or 20s, but we don't have the technology to grow it over a vast space. But it's going to come. It's going to come either in a way that's something that you cover the joint with, or you inject it into the joint, or you regenerate new cartilage. I think it would come at some point, or maybe something artificial that simulates a joint better than a joint replacement. But the problem is that once you get to a joint replacement, there's not only erosion of cartilage, but there's erosion of bone. And so it alters the alignment. So you have to fill that gap with something. So that's where it gets difficult. But I think that we're always looking for stuff like that. But it's so funny. When I was a resident 25 years ago, we kept saying, oh, in 20 years, we'll be able to grow cartilage. You won't need a knee replacement. And then now we're sitting here 2025 and we're like, oh, in 20 years from now, we're going to do it. So we just keep kicking the can down the road here. But I think that we're still looking for stuff like that. And that's a very difficult space. I think that's a big jump. But listen, we're always moving, we're always creating and thinking about where are we going to be next. And that's the exciting part.
Yeah, it's actually, that's interesting you say that, because 30 years ago is when I tore my ACL in a ski accident, and I was in my 20s. Yeah. And then I saw 6 doctors, and 3 doctors said, do the surgery, you're young, you'll regenerate. And 3 said, hold off. I think in next 20 years, there's going to be some new technology, even though you'll be older, but it'll be less invasive. And 30 years later, I never did anything.
Yeah.
And it's like you said, kicking the can. And I keep thinking, I know maybe one day, it doesn't bother me right now, but who knows?
Yeah.
And it's one of those things we'll have to wait and see and just hope that. But it does seem with AI, for example, like technology is moving so fast. And I imagine the medical field as well. Things
absolutely
coming out real soon that I just don't know what they are. But
yeah, so many aspects of medicine are going to change. Radiologists, right? People reading a human reading an X-ray or an MRI is going to change. I mean, it's going to be mostly AI driven, and there'll be some radiologists that need to read some specific things, but like mammograms, MRIs, all that stuff is going to be read by an AI-driven computer, a robot. And then so many things in primary care, like colds and drawing blood and all these things are all going to be done by robots. It's going to change medicine in so many different ways. But like we said earlier in the podcast, humans need human touch. Humans need to have an interaction. And no matter how many robots there are, you want a person to take care of you. You want a surgeon to take care of you. So I don't think there's going to be robots doing everything. You need to have a person be responsible and have a connection. You can't be living in a computer world like in these movies. So I think that you have to, the human connection is so important, and it's so essential to the way we live our lives.
Yeah,
absolutely.
Yeah, there'll always be a space, I think, for us. I want to go back to the muscle, because you did say one of the most important things to do is maintain muscle mass before getting surgery, as well as after surgery, and getting your protein in and doing your rehab. But for me personally, when I heard that, I discovered blood flow restriction. And there's these bands that you put in your arms. If you're on YouTube, they'll kind of look like this. You just put them on, you fill it with air, and then you can help stimulate growth hormone. It helps with recovery. It helps when I was not able to move, and mobility got less and less, no impact, no this, and I just couldn't move my legs. I was strapping these things on every single day, sometimes multiple times a day. And I saw that I was able to maintain my muscle mass, even grow muscle mass. If I have 2 pictures of myself that I put like a year and a half apart, and right before my surgery, and then the year and a half before, and they're exactly the same. And you don't see the change in my muscle mass. So I was so impressed. And then of course I use them for rehab, and after with both surgeries, and I continue to use them all the time. But what are your thoughts in terms of using these types of bands for pre or post surgery?
I'm a firm believer in them. I think that there's a reflex and a response that your muscles have with blood flow restriction that can build muscle greater than sorry about that, jumped out. Can build greater than you can on your own. And I've seen patients where they've had previous ACL surgeries and previous operations where they lost a lot of muscle mass. Like they have an ACL done and they lost so much of their quad, and they're sometimes a year out from that surgery, and we make them do blood flow restriction, and all of a sudden the muscle just bounces back really quickly. And so I believe in that technology. And I also think what's interesting is that you can't put blood flow restriction for your glutes, right? Because it's kind of down on your thigh. Mm-hmm. But what's interesting is that a lot of people talk about the muscle as being an endocrine organ, where it releases hormones and different cytokines that come out into your bloodstream that can enhance the way your body heals. It can enhance your metabolism, and it can also make your body grow more muscle and really build on itself. So I see people do blood flow restriction on their leg, and their glutes get stronger while they're strengthening their glutes. So there's something about it that creates this kind of release of these hormones that allow your body to gain muscle much better. So I really believe in it, and I think it's really critical to do it for patients pre and post surgery.
Yeah, I'm glad you said that, because I just interviewed with Dr. Vonda Wright, and she's absolutely understands it as well. My surgeon in Spain was like, I don't know what you're talking about. I was like, but I think every surgeon needs to see these, because when I discovered them, I started Googling on YouTube, and I saw there was 2 camps. There was either the bodybuilders trying to get some extra gains, and then there was the rehab people and the physios and talking about it. And I just thought, this is unbelievable. Why aren't more people using this? And so she was a big fan of the Suji bands. And there's many out there. I've used so many. I have 3 or 4 sets of different things. They're all fabulous. I don't know if you have one that your patients normally use, or you just say whatever they have.
Yeah, we usually defer it to the physical therapist. I mean, we write it a lot in prescriptions, and we communicate to the therapist to use it. I don't have a specific brand that's my favorite, but I think it's an incredible technology, and it's something it's very powerful. And I've been very impressed with how people kind of bounce back from significant muscle loss, from all kinds of injuries. It's very impressive. And what's also impressive is that you sometimes don't have to do as much exercise, I found. Like they say, like, I can actually cut my exercise time in half sometimes because the muscle responds so well. I do less work on my quads with BFR, with the blood flow restriction, and I gain more muscle, which is so interesting. It's more efficient.
Yeah, the body thinks it's doing 1,000 burpees when you're just sitting there. And there's a lot of research on it, and it's quite unbelievable the type of research they do on people literally just having surgeries, and they don't exercise. They just put the band on, and they still have less atrophy than those who don't put the band on. So it's
absolutely,
it's incredible that you can save a lot of muscle mass as well. You'll of course gain more if you actually do some leg lifts, which you can do, right? From day one, you're probably getting your patients to walk or to do some kind of
Absolutely.
bridges or whatever you can, and you have the
Yeah.
and you will have less atrophy or more gains. So I'm glad that you and Dr. Vonda, there are some surgeons out there who understand, who know what it is.
Yes.
It's the physios that really work with, you're right, with the patient, because they have to teach them. There's bands that are simple and easy, and there's a cyclical nature to it. And then there's the ones that are just a little bit more constrictive, and you're like, oof, you feel the tightness, different pressures.
Yeah.
I'm a huge fan. I could talk about blood flow all day because it just saved me.
Yeah, and I think in an elderly patient, like you're 75, you don't want to squeeze some guy's leg to kingdom come. So I just think it's like there's different levels. And I think it's important for people out there to understand you don't have to squeeze your leg like it's going to chop it off. Some people can withstand more pressure than others, but some level of pressure from the blood flow is beneficial even in an older person that can only stand a certain amount of pressure. I think there's benefit to that as well in an older person.
One question I have about, let's talk about anyone, I guess, over the age of 40, 50 who had some bone scans, I guess, are ready to see you, and they may have come to you and said, oh, by the way, I didn't know I have osteopenia or osteoporosis, and they're concerned about that. And that happened to me. I found out I was like, osteopenia, not of the hips, but of the spine. So I was like, what?
Yeah.
And actually, I've taken another scan called a REM scan, which I think you should also look into if you don't know what a REM scan is. It looks at bone strength. And actually, my bones were actually really strong, surprisingly. So you can have osteopenia and have a strong bones, but the game is still to always to get the bone strong no matter what. And so there's a big trend going on now with weighted vests. So I bought one and I thought, I'm going to do this. And then my surgeon said, not so fast. You have a hip replacement, and I don't think you should be using those quite yet. Do you have any thoughts on that?
I don't restrict my patients to use. I think that weighted vests are great. I think there's an advantage to them to add some weight to your body. I'm not a believer that you should wear a weighted vest all the time. Some people say, I'm going to wear a weighted vest like all day long, and that's going to be part of my wardrobe. And they make these jackets and shirts that are weighted. And I think it's really great to go on a walk or a hike or do some working out at your gym and wear a weighted vest to add a little bit more stress on your body. There's that exercise called the farmer carry, where you carry like a couple weights in your hand and you kind of walk around. I mean, I think there's advantages to that. And there's a facility that's in Los Angeles, I think it's around the country, called Osteostrong. I don't know if you've heard of it, where basically you just have an intense resistance. So I think some level of increased resistance on your bones, whether it's working out, weighted vest, weighted squatting, lunging, leg pressing, is good for you. And I think that will add some bone density to your body, especially in women who are very lean, thin, frail women that just don't have a lot of bone density. Adding that extra weight can really make a big difference. So I believe in it. I think it's fine. I don't put any restrictions on my patients to wear them with hip or knee replacements at all. I don't think the wear and the level of strength of the plastic in these joints are so strong, it's not going to cause any problems. I do think that when, like anything in life, you take it to extreme, when these people are wearing like 40-pound vests, super heavy, or like heavy vests. Like I had a woman that had osteoporosis and she wore this like crazy heavy vest, and she would hike all up and down the Santa Monica mountains, and she ended up getting arthritis in her hips because she was putting so much weight on herself. She wore out her hips like quickly. So I think that those things can happen if you just take things to the extreme. So I think that you have to be careful. But I think, like, for example, a 10-pound weighted vest is a reasonable thing that you could wear when you work out or you go on your daily walk. I think that's very healthy, and I think it's great.
Oh, good. Okay, I don't have to throw it away. I'm going to keep it.
Yeah.
There's the same question about power plates and vibration. People with hip and knee replacements, is this something safe for them, or is it case by case?
I think power plates are fine. The only thing about power plates is that in the beginning of the surgery, like the first couple months, we don't like patients to wear them because the implants are sitting inside bone. And if you create a lot of vibration, you can create micromotion between the implant and the bone, and that could potentially prevent the bone from growing in the implant. So that could create loosening, right? So I think in the beginning, it's not a good idea, like the first couple months. But I think beyond that, it's totally safe. And I think there's benefits to it as far as for balance and coordination and people that do workouts on the power plates. I think it's fine.
Oh, wow. Okay. That's good to know too. So I know you have to go. We've gone already over time. And so I will get to the last question. Do you have a second?
No.
Do you have to go now or?
No, I have time. Yeah, go ahead, please. Yeah.
Okay. I just could talk to you all day long. This is too fun.
Yeah, it's great. It's
Too
great.
personal. I'm sure that if anyone's listening, it's still until now, it's probably because they're considering surgery or not, or recovering.
Yeah.
So, okay, just a few more questions then. So as I would say, okay, there was one interesting one that I wanted to ask you. Oh, yeah, because actually you've performed hundreds, I don't know, thousands of surgeries now.
Thousands, yeah.
Thousands. Mm-hmm. What's one common mistake people make after hip surgery that slows their recovery?
I think the biggest thing, the mistake they make is they overdo it, right? So they say, oh my gosh, I feel amazing. All my hip pain is gone. I'm going to go walk 5 miles, right? If you do that, you don't hurt the actual implant. Like, you don't hurt the operation. You'll still recover, but you'll stress the bone so much that you create massive amount of pain. And it really creates a massive setback in your recovery. So like, this actually recently happened. I had a patient who was in the music business and he was feeling great. And there was a music festival. He was like about 3.5 weeks out from surgery. He goes to the music festival and he's walking around for like 10 hours a day. And he stressed his bones so much that he basically could barely walk. It was almost like, and I was worried. I'm like, oh my God, did he disrupt something? And did his hip get loose? So we looked at him, we did some testing on him, and everything it was okay, except that he really stressed out the bone on his MRI. He had a lot of stress on the bone. And he's better now, thank God. I communicate with him, and he's totally fine now. But that can really slow down your recovery and make you have a lot more pain and a lot more discomfort. We do these surgeries, and we don't cut the muscle, and we use a robot, and we do all these fancy things, but we still rely on the human body to heal. We rely on the body for the first 6 to 8 weeks for the tissue to heal and for the bone to integrate into the implant. And you can't speed that up. You can't make that happen in 1 week or 3 weeks. It just takes time. And so during that time, it's important to listen to your body, and it's important to walk. But in the first 2 weeks, I tell my patients, you walk 7-8 times a day, little 5-10 minute walks. You just keep moving. You just keep moving. And then as 2 weeks go by, you go a little bit farther and a little bit farther. You just kind of listen to your body. You try not to overdo it. And I think that's the biggest thing, is just letting the body heal. You're going to eventually get to the point where at 6 weeks, that's when I let people do Pilates and yoga and start tennis racket and hitting the golf ball. 6 weeks, we let a lot of people do a lot of things. But you got to give yourself that 6 weeks to heal. And I think that's probably the biggest thing that we try to communicate to our patients, is that you got to heal. You got to let your body heal and take it easy.
Wow. Okay. You would be really interested to see my surgeon here in Spain. I couldn't drive for 3 weeks, no car. And so basically,
Oh, wow.
Don't go out too much. And I am now 7 months out, and he says I could start yoga at about 6 months out, and
Wow.
still not allowed to do impact. He said at 8 months you can start impact, like running or something. And I have a physio, and he's like, I don't know, he's not so in agreement, but he said, run 10 minutes, 10 seconds, 10-second run, 2-minute walk, 10-second run, 2-minute walk. I guess in Spain, they're really cautious. And I'm sitting here going, I feel great. When can I start doing all the things I want? And today was the first day I actually did a group class. Like, I've been doing private physio for 7 months now.
Yeah.
10 months with the other hip.
Wow. Wow.
Big difference, huh?
Yeah. So that's a big difference. That's a very slow progression. in Southern California, people are highly active here.
Yeah.
They're like chomping at the bit to like get out there. I'm different. I let people get on a stationary bike at 2 weeks.
Yeah.
And then with some resistance. And then I let them do yoga, Pilates. I let them start hitting a golf ball, getting on the tennis court at 6 weeks.
Oh, wow.
And then
dream for me.
And I let people snow ski and surf at 3 months. So we let people do a lot of big things. I had a patient who I did a knee replacement on, and he was skiing in Aspen at 3 months, up and down the mountain and doing his thing. So we let people do a lot of physical things. The biggest thing I think that we restrict is running. I think that the running part is very hard on the implant and hard on the plastic. And so a lot of running, we prefer you don't run. Mm-hmm. But if people want to run like playing tennis or pickleball or padel, they can do that. Or if they want to sprint, like if you like walk for 10 minutes and you want to run really fast for like a minute just to get your heart rate up, just to break a sweat a little bit, I think that's totally reasonable. But I just think the constant pounding of running 3 miles 4 days a week is just too much for the joint.
Oh, that's good to hear. And I mean, it's quite specific. So thank you for clarifying that. And I mentioned, there's a big difference, I think, with surgeons that I've seen in Europe. And whenever I speak to an American surgeon, it's very different. And you said, mentioned that, what was it? I can't remember anymore, but it's incredibly different, the recovery. And that's why I was so keen to find somebody here. But Europe is just slower. And it could be that the technology is just not as advanced as you have in the US. And that's what they need to do in order to make sure you don't go kill yourself.
The surgeons in different areas of the country are a little different because of the demands that the patients make. But it pushes us, because we live in a very highly active society and world, the patients demand a lot more from us to get back to their things that they love to do. My patients are like, I'm not interested in just walking. I want to do 100 different things. I want to go climb Machu Picchu. If you look at my Instagram, I had a patient I did a total hip on. She's actually a physician. She climbed Mount Everest.
Oh my gosh, you're kidding me. Wow.
Yeah. Okay. With a hip replacement. Yes. And then she also became the first woman she climbed like a whole bunch of other peaks, like I think 7 or 8 peaks, like a whole bunch of them. And she became the first woman to climb all those mountains. She's a big she's actually she's from Vail, Colorado, and she's an internal medicine doctor. And she's been incredible. She came to visit me just for like a checkup, and we did a little thing on Instagram with her. But it's just incredible what people can do, and so it just amazes me how well people perform and how well they do with these operations. And that's what part of what I do is I like we talked about, people getting depressed because they feel vulnerable and they feel like, am I going to ever exercise again? Am I ever going to be the active person that I was? And a lot of it just educating them, like, this is not the end of your life. You're not going to be sitting in an old folks home being wheelchaired around to watch the TV, you're going to be an active person again. You're going to get your life back. You're going to be able to travel and go places and be happy again. And so it's just really encouraging them because they don't have a perspective. But one of the great things I think about my practice is that, we have patients at different stages of surgery coming into the office all the time. And so you'll see a patient and they'll be like, I need a hip replacement. And the patient will be like, oh, I just had mine. I'm a month out. I'm doing great. I'm doing this. And so they, like you said, I've never had a hip replacement. I've never had these surgeries. I do them all the time. For me, it's like brushing my teeth. It's like I do it every week, every day. But these patients, when they see other people and they see the actual flesh and blood of the patient actually recovering and happy and getting back to their life, it's very impactful. That's why, like you said, talking to patients that have had it done makes a big difference. And we do that all the time. We connect the patients together. And what happens is it's a perpetual thing. Like, we'll see a patient in the office today. We'll say, 5 years ago, you operated on one of my best friends, and she did great, and she's so happy. And now I need mine done, and I'm going to come to you because she did so great. Because they see the reality of it. It's not like you're going to be in a wheelchair forever.
Yeah, no. If you don't get the surgery, you will. That's the problem.
You will be.
And I always tell people I'm bionic now. I'm so excited. Like, I have 2 brand new hips, like 2 Porsches, just ready to go.
Exactly.
And some people think,
Exactly.
oh, I'm sorry you're getting surgery. I'm like, no, no, sorry. No, I get to do surgery. I'm
Yes.
privileged. I know
Yeah.
people who cannot, or they're on waiting lists,
Absolutely.
can't afford it. And
Yeah.
I know this is a good thing. Let's be happy. There are worse things in the
Exactly.
world. So
I
it's the
know. I know.
attitude, yeah, counts a lot.
It's
So
so good.
okay, you're one of the most famous orthopedic surgeons in the US. So, what are some of the key health markers that women should really be looking at during menopause to protect their joint health so they don't get into this space in the first place?
I think the key markers, in my opinion, are the hormone levels, like we talked about, like estrogen, progesterone, looking at the levels of that in their system. I think it's also looking at other factors, like, for example, some women have anemia. They can have some kind of chronic anemia in their system, making sure those levels are right. Of course, vitamin D is very important, looking at those levels. And also, a lot of these women, and I've noticed this, I'm not an expert in this, but I think that a lot of women are actually being put on testosterone as a supplement to help with their muscle mass, because that's part of the pathway, the hormonal pathway. So sometimes testosterone treatment, in addition to the hormonal treatment, can be very effective. And then also, as well as bone density, looking at the bone density of your body and that. And I also think the other thing that's really critical is, like, every woman should be evaluated either by a physical therapist or like a well-educated athletic trainer or somebody that's in the physicality of the world, to get a sense of their strength, of their balance, of how strong they are. Because you'd be surprised how weak some people are in certain things as far as balance and strength, and just getting a full assessment of their skeletal strength would be very important as well.
One thing you didn't mention that I think is something, because the world you live in is movie stars and musicians and athletic people.
Yes.
When I was searching what to do about osteoarthritis and my joints, it was lose weight. I was like, that's not me. But most people, evidently, obesity or being overweight is hugely impactful on the joints. Too much, like you said,
Yes.
weight invest all day long. And perhaps, I hate the word weight loss, but it's just, yeah, getting to a healthy body weight, maybe also something protecting
Yes.
joints.
Yeah. And I think that I always think about, I had a patient once that needed both her knees replaced. She had horrible knees. And she went on this health kick and lost like 60 pounds. And she literally came back. She goes, my knees don't hurt. I
Oh,
have no pain. And
yeah.
so all of that, taking that weight off her body, she got rid of all of her pain. She ended up coming back to me like 6, 7 years later to have her knees replaced, because then they got to be painful and they wore out and they became angulated and painful. So I think that, yes, I think that body composition is very important. And there's a lot of controversy right now with all these GLP-1 medications, because it creates a kind of a malnutrition of your body, and you end up losing a lot of muscle mass. Like, we see that a lot with patients, that they lose muscle mass with this medication. So I don't know if that's the ultimate solution for weight loss. I think that it helps people, but I think that eating better, exercising, but really what you're putting inside your body is the most important thing, and making sure your diet is corrected and seeking help. I went on a health journey myself. I met with a nutritionist. I learned what the good things to eat and the bad things to eat. It helped me a lot. And I continue to listen to podcasts and read books about diet, what are the important things to eat, and protein. It helps me be a better doctor. It also helps me be healthy as a person. And so I think that seeking help is important. Don't be afraid to go sit with a nutritionist for an hour and get some educated on these things. It's great.
Good for you for taking care of your health. Yeah. 'Cause if somebody's in charge of your body and
Yeah,
keeping you open, you want them to be in a good condition, right? And not panic.
exactly.
Oh, okay. My last question. I don't think I've had a podcast ever this long, to be honest. I never go over an hour. And
Okay, right,
boy, I
great.
just am so intrigued. My last question,
About.
I want to talk, because you mentioned you were on your feet all day, and how important is getting proper footwear and joint health? Does it matter at all? And what should maybe a menopausal woman look for in a good shoe?
Yes, great question. So I think that shoe wear is very important, because It's your connection to the ground. And there's a concept that we talk about called the kinetic chain. When you take a step, energy is transferred from your foot throughout your body, and that impact and the stress on your body can affect from your ankle to your knee to your hip to your lower back, can affect it. And if you have bad footwear and footwear that collapses in certain ways, it doesn't give you proper support, or the cushioning wears out, the impact on your body over standing for a long time or walking for a long time can create more joint reactive forces, which can make your joints wear out, create more pain, create more discomfort in your body. So this has been a personal passion of mine to have footwear, especially for people that are on their feet for a long time and that work for a long time or stand for a long time or moving. So it's important for people to have footwear that is resilient. And if people say, well, this is my favorite pair of shoes, I've had these for 5 years. Like when I hear that, I'm like, what are you doing? Like, why are you wearing this one shoe? They're like, it doesn't last that long. It lasts maybe 3 months, 6 months, and then the shoe's done. Get rid of this shoe. You got to buy new shoes. This has been a big passion of mine. And I actually started a company called Snibbe. It's a parody on my last name. And that is a shoe. And I developed it with my partner, Daniel Shemtob, who's a chef. And so I helped design the shoe as an orthopedic surgeon for better contact on the foot, allows your foot to swell, but it's a working shoe. It's a shoe for people that work. It's for chefs, for nurses, for people that work on movie sets, for people that stand a long time. But we also have versions of the shoe that regular people can wear. They can walk and they can exercise with, and they can go on hikes with and wear it in all kinds of environments. I'm very passionate about it. I think it's very important that when we built a shoe, that what people don't understand about shoe wear is that when you buy a running shoe has a cushion. The material that foam is made out of doesn't last that long. So what we did is we made shoes that have a foam and a resilience where it can last a year and a half, where another shoe would only last maybe 3 to 4 months. Mm-hmm. And so when you see people working in hospitals, many of them wear running shoes, and those things do not last very long. But we made a shoe much more resilient and made it with a slip-proof sole. It breathes, but it's also water. Some of them are waterproof, slip-proof, and it really allows people to have much more comfort. But I think a lot of people wear all kinds of shoe wear, but a lot of them wear out, and they're not resilient enough and supportive enough for them. So I think it's very important to have a proper shoe wear, whether you wear a pair of Snibbes or a pair of Nikes or whatever brand that you love, but just keep replacing them. Or sometimes I tell people buy 2 pairs, but every 6 months you buy another 2 pairs of shoes. So they'll last that 6-month period of time.
Oh, wow. Okay. I've got to get rid of some of my shoes that have been like for too long. And I didn't realize how much of an impact they had on my joints. But what about the shoes, the boots and the heels? And those are probably horrible for you, but I can't throw them.
I know.
We just have to just replace those or just not wear them as much.
That's a whole nother thing of women's shoes and high heels and different things that women wear in the workplace. That's hard. I tell a lot of women that are my patients, or when I interact with people about shoe wear, about you need to have a pair of shoes in your office. Like when you go walk to lunch, and when you're going to go like walk to the next building that's half a mile away, throw your heels in your purse and put comfortable shoes on and walk to that area with your comfortable shoes, so you don't create all these horrible joint reactive forces, and so you can be comfortable. But then when you're in a presentation, when you're in a meeting, you have your high heels on. But the rest of the day when you're in your office, wear comfortable shoes. Wear shoes that are comfortable to be in, or take your shoes off and go barefoot in your office while you're working, so your feet are free and you're not putting all that pressure on your feet. I think that's very important.
Oh, okay. I'm definitely doing that. I'm so lucky I got a pair of Snibbes yesterday.
Yeah.
Just in time.
Yeah, I'm glad you got them. They're great. Those are called our Rovers. So those are the shoes that we make that are the everyday shoe. You can exercise in them. I use them in my gym. I work out with a pair of Rovers. I wear those in my clinic. Those are just great, super lightweight. and super comfortable. You just see that the resilience of the support is incredible as far as walking and exercising and just walking around through life. You'll love them. Hope you enjoy them.
I was wearing them, all half a day yesterday and then today, and I went to the gym and I showed them off, and you can see it's a really good.
Nice.
This is quite durable and super comfortable. So I'm glad I actually have a decent pair of shoes, and I'm going to chuck my other ones out.
Good.
It's like those.
Yeah, good.
Way
Good,
longer
exactly.
than 3 months, way longer than 6 months. I'm really grateful. Thanks for sending those out. That's been really exciting.
You are so welcome.
No, I appreciate
Our
that.
pleasure.
And I'm going to have to let you go and get back to work because I've taken way too much.
I will, I promise.
It's been so fun. I really enjoyed talking to you.
Yes.
And if anybody wants to get a pair of these Snibs, I'll have a link in the show notes. It's SNIBBS.co, not com. And I'll have a link. I think I have discount codes. I don't remember what it is, probably Zora, but I'll put it all in the show notes. And if you try them out, you have to tell us what you think, especially if you're a chef or on your feet all day, a nurse or surgeons, anyone.
Absolutely. Yeah. Anyone on their feet. We have millions of people that wear them just to wear them. They just like them to exercise and walk around the world with. So it's a great shoe. I think people will enjoy them. And thank you. I hope you enjoy yours.
Yeah.
And thank you for having me on the show. I really, really enjoyed it.
Oh, I'm glad. Yeah, you were so fun to talk to. I can see you got an incredible bedside manner. I know it. And if anybody wants to reach out to you, they can find you obviously on Instagram and YouTube, TikTok, and I'll have all those links in the show notes. It's usually Dr. Jason Snibbe. And where else would you like, you also have your website, drjasonsnibbe.com. Where else would you like them to go or to know?
Yeah, they can contact me through my website. There's an email there, a phone number if they want to come in and see me. That's the best way to contact me.
All right. Get on the waiting list, guys. I'm sure he's totally booked. But yeah, it's been a pleasure. Yeah. And I hope, next time in LA, I'll stop by and come and see you and say hello. And obviously I'm just very fascinated, learned so much from you and excited to see where robotics goes and watch your practice continue to grow and grow. All right.
Thank you so much. Thank you for having me. And yes, please come visit us when you're in town and have a great day.